So for the anatomic syndromes, so we have done the physiologic syndromes. Now we'll do the anatomic syndromes in neuropathy. The anatomic syndrome in neuropathy, we have one, radiculopathy. You have two terms that you have to know. You have radiculopathy and you have neuropathy. Is it clear? Actually, neuropathy that we have been using all around is not actually neuropathy. It is a nerve disorder. When you say neuropathy, you actually mean that there is a particular term, anatomical syndrome, that is neuropathy. Now, what's the difference between radiculopathy and neuropathy? Radiculopathy is when you have a disorder of a spinal root, a spinal nerve root. Is it clear? Coming from the spinal cord, that spinal nerve root is going to be a radiculopathy. Why a neuropathy is when you have a problem with the nerve bulk. Is it clear? So coming from the distal aspect, in the peripheral region, you have nerve bulks. Is it clear? So when you have a disorder of a nerve bulk that supply a particular muscle compartment, is called a neuropathy. But when you have a disorder of the spinal root, is called a radiculopathy, though we are all terming that neuropathies. Actually, that is the typical definition that you have to have in mind. Is it clear? Now, generally, how do you distinguish between radiculopathy and neuropathy on your history and physical examination? Radiculopathy, they usually present as electric current shooting from, you have electric current pains shooting from the vertebral column. Is it clear? Shooting from the vertebral column up to the periphery. Is it clear? So when you have electric current that shoots from the vertebral column up to the periphery, it is a radiculopathy. Is it clear? But generally, neuropathies, they are disorders that instead come from the periphery toward the center. Is it clear? So you have disorders starting at the periphery and then they are progressively moving up toward the center. Is it clear? So here you have electric current shooting pain from the vertebral column, that is the center, and going toward the periphery. Is it clear? But in neuropathy, you have disorders like sensation, that's the sensation disorder that starts from the periphery and progressively go toward the center. Or you have motor disorder that starts from the periphery and progressively goes toward the center. I hope you're understanding. So those are the elements that you have to know on radiculopathy and neuropathy. Now, physical examination for radiculopathy. What you do is that you tap, you percuss at the level of the vertebrae, percussion of the vertebrae. Is it clear? Percussion of the vertebrae. Percussion of the vertebrae can either elicit the dull bell sign, or it can also elicit the radiculopathy sign. Is it clear? Radiculopathy sign. Now, the doorbell sign, how is going to elicit? So when you press at the level of the vertebrae and then the patient has pain at the level where you are pressing, it is the doorbell sign. It just tells you that you have a compressive spinal cord, a disorder. Is it clear? When they say it just tells you that there's a compression of the spinal cord at that level that you are pressing. It is not the same as the radiculopathy that you are speaking about. So if you are pressing at the level of the vertebra and then the patient just have pain there, the patient is not going to is not having radiculopathy, but is instead having a compressive spinal cord disorder. Now, the next thing is if the patient has radiculopathy. When the patient has radiculopathy, you press at that level or you percuss at that level, and the patient starts feeling electric current radiating from the spinal root at which you are pressing. Is it clear? It means that the patient is having radiculopathy. So if you press at the level of the vertebral column, let's say that you press at the level of the T1 vertebrae, and then the patient started having pain at the level of the T1 sensory root. Is it clear? It means that all the T1 starting from the vertebrae and then radiating to the T1 sensory root, it means that the patient has a radiculopathy. That's how you elicit radiculopathic pain on physical examination. But for a neuropathy, you have to do a physical examination for the nerves now. For the sensation, you have to assess for the sensory of vibration, the motor, the proprioception. Is it clear? So you assess for the sensation. Is it clear? And those sensations, generally, they are going to be transferred by different histologic structures. And particularly, you have to know that what in the case of diabetes, the first sensation that is going to be lost is the sensation to vibration. Is it clear? So it's very important that you are going to assess for vibration in this type of patients. Is it clear? So you're going to have sensation to vibration, and we have another peculiar test that you have also to do here. Is it clear? So you have to assess for sensation in vibration in this patient, because they are histologic. The histology, when you have certain pathologies, they say in those pathologies, certain histologic structures or histologic nerve that transfer certain receptors of the pain are going to be different from others. Is it clear? So that is for neuropathy. So you assess for sensation to all those sensual, and then assess for motor. Is it clear? For motor, you have to assess the different motor regions. Is it clear? Is it, you assess for the different muscles with respect to their nerve bulk. Why here, if you want to assess the different muscles here, you're going to assess the muscles here with respect to their myotomes. Is it clear? Here you assess the muscle with respect to their muscle bulk, that is from where they are supplied, and here you assess the muscle from their myotomes. You assess the sensation here from their dermatomes in order to locate which root is having a radiculopathy. Here you want to locate which nerve is having a neuropathy. Is it clear? But here you want to locate which root is having a radiculopathy. So at the end, when you have a radiculopathy, you should say a T1 radiculopathy, a T2 radiculopathy, particularly if they are monoradiculopathies. That's why you have to know that what in radiculopathies, we are going to have different elements in it, and neuropathies. Is it clear? You have different elements in it. In radiculopathy, you can have one monoradiculopathy. Monoradiculopathy means that it's only one radiculopathy, means that it's only one nerve root that is affected. Let's say that it's only T1 that is affected. You have a T1 monoradiculopathy. Is it clear? So that's why you have to identify the sensation, the myotome and the dermatome that is affected in T1. Is it clear? To know that it's a T1 monoradiculopathy. Is it clear? Now, in neuropathy, it is a nerve radiculopathy. Now you need to know the different nerves of the body. Like in the case of a median nerve, when you have a case of a carpal tunnel compression, and you have a median nerve, when you have a median nerve injury in a carpal tunnel compression or median nerve palsy, you see that in that case of a median nerve palsy, it is a median nerve mononeuropathy. Are you understanding? Because it is only the median nerve that is affected there. In this case, you have to assess the muscle and the sensation of a nerve. It is not a muscle and sensation of a root. Is it clear? For the root, you have dermatomes and myotomes. Now, if you want to know the neuropathies, in order to do a good physical examination, do a muscle and sensation of a nerve only, like in the case of a median nerve neuropathy. So those are mononeuropathies. Is it clear? Median nerve neuropathy is a mononeuropathy. The second thing, in radiculopathy, you can also have a polyradiculopathy. Is it clear? You can have a polyradiculopathy, meaning that multiple nerve roots are affected. So you say the nerve roots which are affected in this polyradiculopathy. Now here also you have polyneuropathy. Is it clear? Polyneuropathy means that there are multiple nerves that are affected. They are not nerve roots, but they are nerves here that are affected. Multiple nerves are affected in polyneuropathy. So you have to say which nerve. Is it the median nerve plus the radial nerve plus the ulnar nerve? So you have to say which nerve. So you have radial, ulnar, polyneuropathies. Is it clear? Now, the third one after that, you have. So those are the two major radiculopathies that we have. The other ones are on the neuropathies. Neuropathy, we have also ascending neuropathy. Ascending polyneuropathy. Ascending polyneuropathy is peculiar because it is going to progress in a stocking glove pattern. Is it clear? So when you have a patient that has lost sensation as a stocking glow sensation, starting from the tips of the finger. Then it is going to be as loss of sensation as if you have wear a glove, sensation on the part whether you wear a glove, or sensation of the part that you wear stocks. That's why it's called stocking glove pattern. When you have loss of sensation on those parts, it can be associated with ascending polyneuropathy. And every time you have ascending polyneuropathy, for your etiology, you always have to ask yourself if there is a Guillain-Barré syndrome. It's the one that usually presents with that ascending polyneuropathy. Now, after ascending polyneuropathy, you have polyneuropathy multiplex. Is it clear? So we have multiplex neuropathy. Is it clear? Multiplex neuropathy. In the case of a multiplex neuropathy, here you have what? You have multiple neurons affected on two dissymmetric limbs. Is it clear? On two dissymmetric limbs. Is it clear? It is dissymmetric. It's not symmetric limbs. Normally, if you just have a polyneuropathy, it is affecting the body symmetrically. Is it clear? Symmetrically. When only one limb is affected, generally they call it mononeuropathy, and one nerve on one limb, mononeuropathy. Multiple limb, polyneuropathy is going to be mostly for multiple limb, but it's going to occur in a symmetric pattern. But when you have asymmetric nerve involved from, let's say, the lower limb and then the upper limb, is it clear? Or the lower limb on the left side, the upper limb on the right side, that's a multiplex neuropathy. Is it clear? So those are the different neuropathies that we can have and how they can be associated with the physical examination issue. Now, after visualizing the neuropathies and the presentation, we now need to visualize the etiologies, how the etiologies are going to present, how the complications are going to present.